Looking for a professional office space that makes it easy to focus on growing your business? At J. Kenba Executive Suites, we offer turnkey office solutions with stylish furnishings already in place so you can walk in and get right to work. Our leases include access to Wi-Fi, managed building access for security, on-site parking, utilities, and regular cleaning services, giving you peace of mind and a workspace that's always clean, secure, and business-ready. Whether you're a mental health professional, insurance agent, notary, or other service-based entrepreneur, we provide the professional environment and amenities you need to impress clients and operate efficiently. And if you're not looking for full-time office space but need a place to host a workshop or small meeting, we also offer conference room rentals, perfect for off-site meetings, trainings, and workshops. Schedule your private tour today and see the difference for yourself. Visit jkenba.com. That's www.jkenba.com to learn more and reserve your space before it's gone. At J. Kenba Executive Suites, we provide the professional space. You create the success.
Welcome to the Byja Radio Show. I'm your host, Dr. Byron Jasper, and we are recording live with special production by Becknell Media. All right, people, back for another episode of the amazing Byja Radio Show. It is myself, Dr. Jasper, in the host seat, and if I am saying we are back in the actual Byja Radio studio, that must mean we are talking about myself and the amazing co-host with the most, the myth, the medical mystery, the legend, the person that makes curiosity contagious, the gentleman of all gentlemen. He, I think, was knighted recently, if I wasn't mistaken. That must mean I'm talking about PatientZero, or Sir PatientZero, as I like to call him these days. How you doing, brother?
I'm doing well, brother. I just got in from King Arthur's round table. So, I'm doing well, my brother. How are you?
I'm doing all right. You lost your accent. That's the only reason I was wondering, when you got in. It must have just been, a temporary accent is what I'm hearing.
Well, I had to speak like I was on Shakespeare or something. Like I had to, come hither, stuff like that.
I support it. I support
Yeah,
it.
yeah, yeah,
A
temporary,
hither
man.
every now and again keeps people on their toes, in my opinion.
Yeah, absolutely, bro. Because you never know what to expect from Patient Zero, man. One day I sound like I'm Creole. Next day, I sound like you know, I'm from a Renaissance era, and then tomorrow might be a British accent. Who knows? We'll
I
see.
like it. I like it. Well, today we are going into a topic that I think is very timely. We talked about it before we started this episode, and that content that we discussed came in a kind of a wave, at least on my end.
Hmm.
So a lot of the social media that I have and I follow are obviously medically related and business related. And I see a lot of posts and comments and topics talking about, of course, direct primary care all of a sudden. It's not because it's just myself, but it's now becoming more mainstream that a lot of people are learning about direct primary care from various outlets, various social media platforms and news outlets, because, of course, Patient Zero, as you already know, insurance is about to go through the roof because
Yep.
of recent legislation that seems to be moving forward. The government shutdown may not be shut down much longer or going on much longer. So, of course, with that, that turns into the subsidies that are basically on the table of, do we keep it, do we not? More than likely, if I had to go with my gut, they're not going to be there much longer. So if those subsidies go away, we covered this about 2 or 3 episodes ago. That means more than likely insurance premiums are going to go through the roof. And if they go through the roof, a lot of people are either going to not be able to afford insurance or just flat out drop insurance because they say it's not really worth it. So based
Hmm.
off of that, people are talking about direct primary care. And now with them talking about DPC, we are often getting tagged, and people are commenting and sharing our information, sharing our news, sharing the book that we wrote, trying to tell people that direct primary care has been around for a while. So based off of that, I think today's episode we're going to spend some time really trying to pull the curtain back and peel the layers off of the direct primary care mystery for a lot of people. Now, people who listen to our episodes regularly probably are going to know a lot of the information we cover. But if you're a new listener, first and foremost, please like, subscribe, share, comment, all those good things so Patient Zero can continue doing his world takeover. But I think from there, you'll start to say, okay, I'm listening because I really want to understand this DPC thing and if it works for me. So, Patient Zero, we talked about it first and foremost before we got on. What season is it right now when it comes to health insurance? Two words that you know very well.
Yep. Open enrollment. I know it. I know it very well. So anyone who has insurance and health benefits through their employer, it's open enrollment time. So you have time to is that time of the year where you can select your benefits. So there's a couple of things that I think you should do for sure. We might get to that a little later in the episode, but it's the time where you decide if you want to keep your same health coverage, if you want a more involved plan, less deductible plan, you want vision insurance, you want dental insurance, things like that. You want to contribute to your health savings account if your job offers one, flexible spending account, whatever, all those benefits. Is now time to make those elections.
Right. Absolutely. And the other thing that I'll also add on is open enrollment oftentimes gets associated with employer based health plans, but it also can be for just basically marketplace plans, right? So open enrollment is just the time to select insurance or select the type of insurance you want to carry into the next year.
Yep.
For some reason, somebody came up with the idea that we need several months out of the year to choose insurance plans, and then we're going to drag that insurance along for a whole year, even if it's trash. Never knew who came up with that, and kudos to them because somebody decided to keep that going, and now we just do it, even though it doesn't really make sense in my opinion. But hey, that's what season we're in. So this episode is timely for a number of reasons, not only because the insurance situation is going to a very diabolical space in my mind with the premiums being through the roof, which we'll talk about, but the other part is open enrollment. So based on that,
So,
I think the
so
best thing.
I'm
Go ahead.
sorry, I didn't mean to cut you off, but something just really kind of like triggered me just now in what you just said.
Yeah.
Think about insurance where you can make a decision once a year and you can't change it for the rest of the year unless like you're terminated from the job or whatever. But I can make whatever subscription changes I want every month
Hmm.
during the month. I can go look at my internet plan, change that. I can even if I sign a lease on a rental property, I can pay amount of money to break a lease. So I have flexibility in all these things in life.
Hmm.
But for some kind of reason, I can't change my health insurance, but until the beginning of November. It's kind of weird.
Yeah, very. And I think it's intentional that it makes people confused and there's no real logic or way to understand why it happens that way. But here we are, my friend. So what I think we should do is, really explain to people why direct primary care is necessary. But more important to me, I think it's going to be helpful to kind of paint the picture of where we are right now. Now, we've
Sure.
done this on multiple episodes on multiple levels, and it's been a very what's the word I'm looking for? Separated approach, where we're talking about one part for one very long segment on an episode, but not putting it all together. So we'll start by saying potentially why direct primary care came to exist. And I think to do that, that means we have to start with where things are in the state of healthcare in America. So Patient Zero, we got numbers in front of us. And as always, we like to start with a ton of numbers and statistics to really drive the point home that this is not just hyperbole, where we're just talking because this is how we feel and there's really no rhyme or reason to what we're saying. We are trying to make sure people understand that the numbers don't lie. And the numbers don't lie because It's not stuff we are making up. It's stuff anybody can look up and verify that what we're saying is actually accurate, and it's basically a common experience for people across the country. So based off of that, let's start with just some general numbers, PatientZero. So I think we can start with simple things like just cost, and then we can start talking about things like wait times, the ability to get an appointment, things of that nature. So let's start with what you feel is most important when it comes to the numbers from a cost standpoint. So what do you got for us, PatientZero?
Cool. So for 2025, the average annual premium for family health coverage in employer plans reached $26,993. I'm sorry, $26,993. That's a 6% increase, averaging about $1,408 in increases per year. So basically, a family spent on average 26,993, almost $27,000 on premiums. So what that means is just the cost of their health insurance, $27,000. Nobody saw a doctor. Nobody took a pill. No one got a Band-Aid.
No
They
labs.
just spent no labs, no nothing. You just spent $27,000 to have coverage. In a year where auto, cars are expensive as it is, auto loans have a high interest rate, homes have a high interest rates and are very expensive. You're paying $27,000 a year on average just for the potential of care, not even to get any care.
Right. And
That's wild to me.
And that's a family plan that we're saying comes from an employer space. It could be a lot different if you're in the marketplace. And it also
A lot
depends
higher.
on a lot higher, right? And it also depends on the type of family, right? It could be that this family plan could be a family of 4. If it's a family of 7 or a family of 6, it could be even more than that, right? So 27,000 just for the idea of getting health care through insurance. That's it. Like you said, nothing has actually been delivered. It's not about quality. It's about access through insurance-based healthcare, and you're 27,000 in the hole for your family off the rip. So we automatically know that's a problem. So let's keep going because again, we can spend time on the soapbox, but I want to make sure we get all these numbers in. So what else you
Sure.
got, PatientZero?
So deductibles continue to rise. Among workers with single coverage plans, the average deductible in 2025 is 1,886, up from $1,773 the year before. So the deductible, what that is when you have an insurance plan, you have to reach your deductible before the insurance actually pays for your services or gives some type of discount for services. So that means in addition to the $27,000 you just paid, when you have to get care, more than likely you have to pay this is almost $1,900 in care before you have any type of insurance benefit for the most part, which is another wild stat to me.
Yep. And again, that's possibly an average, right? It could be a lot more, right? It could be a $5,000 deductible, right? It
Yeah.
could be a $10,000. So it just depends. But the deductible is the second part. Okay. And one more stat I think you got for us when it comes to that system-wide approach.
Cool. So for employer-sponsored plans, the total health benefit cost per employee is projected to rise 6.5% on average in 2026, and it could go up nearly 9% without cost reduction strategies. Right. So you hear 6.5%, 9%. You kind of think to yourself, that's not really a huge deal, right? Well, 9% of $27,000, that's roughly about another 2,500 bucks. You know what I mean? Like that's a very significant number.
Yeah, absolutely.
So
And
yeah,
again, that's just kind of basic high level things, right? There are more in depth things that we'll talk about. So, for example, for the Affordable Care Act marketplace, insurers are proposing a medium premium increase of about 18% nationally in 2026. and that's the largest increase since 2018, right? So an 18% increase nationally in the premiums themselves. Like I said, not deductibles, no care is being delivered. It's just your premium is going to be higher by 18%. In some states, benchmark premiums for the mid-level silver plans are projected to increase by about 26% or more in 2026. So again, 18% is the middle of the road. But depending on the plan, it can go up as high as 26% or even higher. And again, we talked about this in depth in a previous episode where we were seeing that some plans could go up 50 to 75% depending on the person. And that really shows that this is not something that's, once the train leaves the station, I don't think it's going to ever come back. So it's something that we definitely are going to see a huge need for DPC if this happens. And when it happens, in my mind, people are going to really say, well, I wish someone would have told me more about what to do, what not to do, and things of that. And that's why I believe people are listening to us today. With that,
Sure.
if enhanced premium tax credits expire, right? If the subsidies go away, the things we talked about previously, many subsidized enrollees may see their annual premiums and payments double. And that means it could be up to or approximately 114% higher, or an increase of 114%. So again, approximately if you're at around $888, let's say 900 in 2025, you're going to be about 1900 in 2026. Like, it's insane how high this is going to be. And people are going to really get hit with that one way or another unless you're really proactively working on it right now. If you're not engaging with someone on the healthcare side who really knows what they're doing, you're going to be in for a rude awakening. And a lot of people don't know what that is because all they're used to doing is just saying, my employer offers me this plan, I just pick one. I don't really know what it is. I don't know how it works. I just pick one. And now they're going to be hit with that extra cost just because the employers are doing the same thing. The employers are not educated themselves. They're just picking stuff. And at that point, they don't know any better either. So both sides are picking random stuff. The cost is going up. There's no alternative. So what do we do? And I think that's crazy. So PatientZero, we got a few more stats. Anything else you want to talk to the people when it comes to the out-of-pocket cost?
So when you talk about these out of pocket costs, um, among people with employer coverage in 2023, the average out of pocket spending was $869 per year, right? So high deductible plans, um, which are actually more common, the median annual deductible for private industry workers was 2750 among high deductible healthcare plans participants, right? That that's a lot of deductible, right?
Mm-hmm.
Because in addition to what you're already paying in increased premiums, you have more that you have to pay before you even use the benefits.
Correct.
And then not only is it super expensive, but once you go to see your primary care physician, the wait times are 3 to 4 weeks or longer. And the average visit is 15 minutes or less. So you're not feeling good. You call your PCP, takes you about a month to get to them, and then they only talk to you for about 15 minutes after you just spend all this money to get to them.
Right. And that's the part I think is crazy for a lot of people, especially people who are in the traditional model. You're paying an expensive amount of premium deductible, just a high amount across the board, and you're getting a lot less. Your
Yeah,
premiums are going up. So you're paying more and you're getting less. I want that to sink in, hopefully, if you're listening to this. And I love the idea that I have good insurance. So therefore, it's okay. It's not,
it's
because
not okay.
most people have no idea what their insurance will or won't cover until they find out what it will or won't cover. You can watch
Right.
stories on stories on stories where people literally have found out after they thought they had really good coverage that there is a loophole or some fine print that tells them that this is not covered, and they are basically at the mercy of the insurance company. Now they have to file appeals and hope that the insurance company really reconsiders and basically gives them favor, only to find that you gave them 27, 35, $45,000 for them to tell you no. I mean, what other industry can you pay $45,000 for a product and they tell you no, you can't have it? I mean, it
You
really
can't.
makes no sense because people just don't know any better. They feel like they're covered and it's not going to be them. And when it finally does happen, they're like, someone told me I should have known better. I don't want to listen because it can't be me. And it won't be me that has that $2,700 deductible. And when I pay it, I know everything's going to be covered. That's not how it works. I'm telling you. So
Mm-mm.
the numbers are not lying. That cost is going up. You're paying a lot more, and it's only going to happen once, twice, three times more. And then from there, you're getting less, right? You're having shorter visits and longer wait times. So, PatientZero, I want to know your thoughts, man. How do you feel about that? I mean, I think, you were in the system on the patient side. I was obviously in the system on the physician side. So I know we both have our experiences, but what are your thoughts about the numbers now and the idea that it's continuing to go down this road, considering what you know and you've been in the model for just as long as I have, about 5 years?
Well, I think it's actually disgusting that we have hardworking Americans who have to deal with this economy and how fast inflation has been moving, right?
Mm-hmm.
We talked about the price of everything. When you talk about, because in all these episodes we talked about the financial strain, right? You
Mm-hmm.
talk about how much it is to own a home, how much it is to have cars now, how much groceries are, and these are basic needs, right? So you're dealing with that already. In addition, you're paying an inflated amount on healthcare and health insurance, and you're not getting the care that you need. Is actually disgusting, and it seems that people are almost being taken advantage of
Mm-hmm.
because they don't really understand what's going on. So for me, just personally, as a patient, I'm not in it on the care side like you are. I'm a patient, right? And when I'm not telling people not to have health insurance. I'm not saying that.
Mm-hmm.
What I am saying is understand what you're paying for and make good decisions. Because just because I have health insurance, that doesn't mean I use it all the time,
There you
or I
go.
don't just blindly pay for the quote unquote good insurance because it has a lower deductible. Because you got to understand what you use.
Mm-hmm.
Being that one of the greatest decisions I've ever made was to say, hey, let me crunch the numbers. I'm gonna go ahead and look at this higher deductible plan, and I'm gonna enroll in the clinic.
Mm-hmm.
And that was one of the better decisions I've ever made because number one, I'm the healthiest I've ever been in my life. I don't have any numbers that are caused. And when I said numbers, that my labs, I don't have any cause for concerns in any of my lab work. I know the range where my numbers are consistently because I get new labs every quarter. I get visits where I can talk to my doctor anytime I want, not just because he's my friend, because that's the way the system is set up.
Mm-hmm.
My appointments are an hour. I don't have any wait times because I walk in, I get seen, I can talk as long as I want, and I get a bottle of water on the way out. It's just a better system of care for me. And indirectly is keeping costs down because I don't have any type of catastrophic issues. Odds are I won't, have a catastrophic health issue. I need to be rushed to the emergency room. I need to be in an ambulance or anything like that. I can still sustain an injury, but I'm getting taken care of. You know what I mean?
Yeah.
And I think, what's helped me a lot just in from a financial point of view and a care point of view is to come up with a plan. I don't just in right now in open enrollment season, you need to come up with a plan and understand how much things actually cost, how
Mm-hmm.
much you spent last year, how much you spending on prescriptions, and take into account all of that. So for me, I come up with a holistic plan. I understand that I'm an individual, so I can contribute up to $4,300 a year, tax free, in a health savings account. So that's a savings right there because if I know how much I'm going to spend, I can spend that and not be taxed on the money,
Mm-hmm.
right? I have a higher deductible plan through my employer. I still like to have insurance because there's no direct care yet, as far as I know, on specialists or for hospital visits or anything like that. So I want to be sure that I have some type of coverage because let's be honest, catastrophic events can really change someone's life, not only health wise, but financially, right? You don't want to be in the hospital with anything and not have insurance because that can actually cause you to go bankrupt. So I don't want that, right? Um, so I do have insurance. I do take advantage of my health savings account, and I enrolled in the clinic. And it actually saved me money, even though I'm paying a monthly membership fee, because I know that's the first thing people go say. Well, I don't want to pay to see the doctor if I don't actually see the doctor. The numbers worked out for me.
Mm-hmm.
So, long story short, I'm gonna get off my soapbox in a second, but really do your research, understand the tools that's available to you, take a look at direct primary care, and don't overpay for insurance.
Mm-hmm.
Look at what you actually use, what's available to you. For me, it worked out the way I lowered my deductible. I enrolled in the clinic and I take advantage of my HSA where I can use that for all my meds. I'm in physical therapy right now. I use that to pay for my physical therapy. It's just, I'm the healthiest I've ever been in my life. And it hasn't been a financial burden on me because I made a plan and I re-evaluate my plan every year at open enrollment time. And I've been good ever since.
Yeah. So you said a few things that I think is worth kind of considering. The idea, like we said, you're paying more for a lot of things, not necessarily you, but people in general, and you're getting less. So if you're paying more for longer wait times, you're paying more for shorter visits. What's the point of literally not changing anything and waiting for the bottom to fall out to then really look and say, well, what else is there? How about doing that proactively, right? So that's the first thing. The second thing is when I looked it up, it said the average wait time to see a primary care physician in the United States is about 26 days. Okay. I'm not great at math, but last I checked, most months are 30 days long. So you can, really want to be meticulous and, oh, it's 26, it's really not 30. In my mind, that's a month. It takes you a month to see your primary care physician, and you're already paying a lot of money. And when you're waiting longer to see them and you're paying a lot of money, that tells me one or two things are going to happen. Either you're going to get sicker or you're going to say something to the effect of, it doesn't make sense to even try to go, so I'm just going to not worry about it. So you're going to defer care,
Or,
right? Go ahead.
or what else can you do?
So from my perspective, or what
No,
they
no, no,
would do?
no. What else? What else in the traditional system you can do? Because you can't get to your primary care,
Right.
then you go to urgent care
Mm-hmm.
and have the same type of experience, 15 minutes or less, may or may not fix the issue, and then they're gonna tell you follow up with your primary care physician
Mm-hmm.
in the 26 days, and now you've spent more money and more time dealing with the same issue. It's just broken.
It's really broken. And I think the other part, to go into one step further, people like to go to urgent care because they feel like, well, they are getting to me faster than the traditional system. That part I'm not going to disagree with you on. And I will agree they will see you faster. That part is intentional. The problem is, and this is me being as blunt as possible, some urgent cares are trash, right? Like you'll have people in the actual urgent care who don't know what they're doing, and they're just giving you a lot of prescriptions. They're medicating you because you have a runny nose and you feel bad. So they give you my favorite, a Z pack, which is antibiotics, a steroid pack.
Steroid shot, yeah.
Okay. And what's the last one? Because there's always three things.
Decongestion,
So some other form of medication for
yeah,
allergies. So they're giving
right.
you three treatments for three different problems, and people walk out and think, well, I feel better, so they must have got it right. No, they're over treating you. And when something really needs to be used, you've had it used so often, it doesn't work as well. So your antibiotics now develop resistant bacteria. So now the Z pack
Facts,
doesn't work anymore. So now the Z pack doesn't work. When you need to get treated with it, we can't use that anymore. So now your illness gets
because
worse
it's not gonna work. Right.
because we've overused it. And people
Question.
don't think that this is a problem because my favorite is, well, I feel better, so that's all that matters. You feel better momentarily, but your wallet isn't better because you're basically paying more. You're still getting subpar care. That's basically microwave care. And then once that happens, you still don't have a primary care doctor who you're seeing to help you not have this happen again. So it's going to be a wash, rinse, and repeat. And we wonder why the cost is going up. And this is something I said earlier in a post on LinkedIn, because I posted about our book, and a young lady actually responded and said, basically, do you think direct primary care can work with basically a marketplace plan, yada, yada, yada? My response to her is the same thing I've said over and over. If you treat direct primary care and healthcare like car insurance, which I recommend everybody think about, you'll start to see how you can save. Because if you're using car insurance to wash your car, to rotate your tires, to change your oil, and any other car maintenance, you're going to have a really high cost to your insurance when it's time to renew it. So what do you really do? And PatientZero, you already understand this. When it comes to those things, what do? Do you really go into the mechanic shop or the gas station and say, I wonder if they're in network? You just ask how much does it cost? And if it's reasonable, you pay for it.
You pay it.
You
Right.
save the
And
insurance
that's all you do.
for catastrophic things like car accidents and damage to the vehicle because you had, you hit something accidentally. So now insurance comes in to do the body shop and da. By doing that, you're filing less claims because you're paying for stuff up front and saving insurance for big stuff. So if we do that, why would your premium go up if you're really not using the insurance? It doesn't. In healthcare, the reason it goes up is we're using the insurance all the time for a copay,
For everything.
for a premium, for the deductible, for the medication, for the lab, for the visit, for the imaging, for the referral, and on and on and on. And then people say, well, I understand why my insurance went up 18%. Well, you used it 18 times in one day, and then you're using it on the weekend, and you're using it when you get a refill, and you're using it when you show up to the clinic. It's claim after claim after claim after claim. And all these claims now cause insurance to skyrocket. That's why this is going to continue to happen, because no one is telling you to stop using your insurance, except for people like myself and PatientZero. We're telling you to use it when necessary. We're not saying you don't need it. We're saying use it for big stuff. And if you do that, it's going to possibly make things work a lot faster. And that's how direct primary care works really well within this system. So
before you go on, I have a question and a comment. Basically, when you doing this insurance and you said with the urgent care, they're over medicating you.
Yes.
So now you have more prescriptions than necessary, which is causing your deductible and everybody else's deductibles to go up, right? Not deductible, premium to go up, right? You brought up what happens when you are over medicated in terms of antibiotics, but you didn't comment on what happens when you are over medicated with steroids. So I'd like for you to comment on that, because you're paying more for it and it's a health risk.
Yeah. So overuse of steroids, the high level is that overuse of steroids can raise your blood pressure, raise your blood sugar. It definitely increases your appetite. It also, over long periods of time, can cause hormone imbalances. And the list goes on and on. I'm just saying those 4 things because it takes a little bit to understand how all of it goes together. But that is going to continue to happen, where you keep getting steroids for an issue because you keep going to urgent care. And again, there's no continuity. Unless you go to the same urgent care 4 times and they get to see you in the same urgent care, the same person hopefully seeing you and the notes are still in that urgent care, they're going to potentially keep treating you the same way. And why do I know this? I'm not saying this because I'm anti-urgent care. I'm saying this because I used to work in an urgent care. I worked in urgent care regularly to pay bills when I was a resident. We call it moonlighting. Moonlighting is basically when you work one job in the clinical space and then you get other clinical jobs to help pay bills. So I was moonlighting during residency because I had bills, right? And I was working in the residency and working in urgent care. I want you to understand what I'm saying. A resident physician is a doctor in training. I was in training treating people in the urgent care as if I was fully trained. That's the first thing. Now, I had sense. Let me put it like that. I wasn't great. I wasn't as good as I am now because, again, with the experience, you get better. So that was the first thing. But I was also responsible for training other people when I was still in training, meaning we had nurse practitioners and PAs that worked in the urgent care. And guess who had to sign off on their notes, PatientZero? The resident physician. The resident in training was signing off on the physician assistant who was potentially longer trained than me and also potentially was supposed to have more knowledge than me. When I tell you I have to say this. When I tell you I got into it, one of the PA, I told him, stop doing that. Stop giving people 4 medications for every runny nose they walk in. And if you feel like you got to keep giving people 4 medications, stop coming to me because I'm not signing on your notes. I literally told him, you're over treating people and it's not right. And we literally didn't talk for the rest of the time I worked at urgent care because I couldn't stand that person over treating people. In his mind, that's the way that it was supposed to be done. You give them 4 prescriptions, they feel better, they leave, and they're happy. And I said, that's not the way you're supposed to do things. It's first do no harm. And if you first do no harm, you don't overtreat people because that's going to harm them down the road. It doesn't matter if they feel better right in this moment. So the point is, urgent cares can have that happen because they're looking to, again, turn people around quickly because it's a volume business. Urgent cares aren't meant to be slow. They're not meant to have slow days. They're meant to get people in and out. So to get people in and out is giving them a bunch of pills. That's all it is. And that's
So
part of a problem. So that was my soapbox.
as somebody, you just said you were in training and you were training other people. So essentially, what you have is a middle school class. Not trying to insult anybody, but just setting up the scene. So essentially, can you imagine like a 7th, 8th grade class with a 7th, 8th grader teaching the class
Mm-hmm.
of his peers?
Mm-hmm.
That's what I heard when you said that.
Mm-hmm.
And so, how successful do you think that 7th, 8th grade is going to be in teaching people? And what type of service do you think you're getting from that urgent care?
Mm-hmm. Exactly. And I think the other part to kind of emphasize is I was a physician at that point, right? I wasn't fully trained, attending, board certified like I am now, but I was trained enough to know more than probably a lot of non-physician uh, employees. Let me say that, right? So the physicians in training have probably done more training than non-physicians, right? Because by that point, I'd
Mhm.
already done 4 years of med school and 1 or 2 years of residency. So I'm 5 years in, whereas some of these people are 1 or 2 years in, right? So that's the
Mhm.
first thing. So I still did know a good amount, but it also is really awkward that the person who's younger than you is now your boss, right? And now you're having to listen to somebody you may not want to listen to because you feel like, well, I'm older and I feel like I know what I'm doing because people aren't complaining. We're going to keep doing that. That's not the way it should work. And I think that's a really bad way for things to be done when it comes to healthcare. And I bring it up to say we're kind of getting into the space of urgent care and the broken system where you're getting long wait times to see the physician, not only between visits, but when you're in the waiting room, which we haven't even talked about. And then it's a short visit. It's basically that one size fits all that we kind of all know the experience. If I said you're going to the doctor and we didn't say what kind of doctor, the first thing in your mind potentially when I say, well, what kind of visit you think it's going to be in terms of the experience, everybody probably says the same thing, PatientZero, and correct me if I'm wrong. A packed waiting room, really old magazines in the waiting room, probably a TV that's not really working or showing you anything you want to see. Then, after waiting for 45 minutes to an hour, you then potentially get called to the back and wait some more. After you wait some more, they then finally come in and they're on skates because they got to go. They're in a rush. They got more people to see and they don't have time to really talk to you. Am I wrong about that? Or do you feel like that's a pretty accurate depiction of we're going to the doctor today?
Nah, that's an accurate depiction, man. Matter of fact, the last time I was in the primary care physician's office, that wasn't the Byja clinic, was the last time I saw you at Baton Rouge General. Man, I was looking at a I don't know, it was like a home and garden magazine that was a year and a half old. I was in the waiting room where everybody in the waiting room was sick. So not only am I not feeling great, but now I'm exposing myself to a bunch of other sick people. And then I think you were training somebody.
Mm-hmm.
So you were trying to talk to me and them in about 7 minutes. Now I give you credit. You was fairly thorough in that 7 minutes, but at the same time, it's nothing like I've received now.
Mm-hmm.
And it's, and you're the same person.
Yeah. Yeah.
So you're actually one of the best doctors I've ever, if not the best doctor I've ever come across. So I can only imagine if somebody has a doctor that's not as good in 7 minutes. Like, I don't know how you get anything done.
I know how you do. It's take more pills, order more expensive tests, see more specialists, and then when you're done doing that, come back and see me for a follow-up visit. And that's going to still take what, 26
But
days?
but
Right.
can I really comment on how irritating that is?
Yeah.
And look, I get sometimes that you have to see a specialist. I understand that. You can't do everything, right?
Hmm.
But as a patient, sometimes it's like, bro, every time I come to the PCP, they have to refer me to somebody else,
Hmm.
and then I have to go do something else. And then it's like 6, 7, 8 weeks have passed, and I'm still working on my little ailment, and I don't feel any better, and I done spent a whole bunch of money.
Yep.
That's a terrible experience
Yep.
for a patient.
And it's business as usual. And the people who are in that system are just playing their part, right? They know the system is bad. They know it's broken. They know it's expensive. They know it's not efficient. And they just kind of do it. It's kind of the analogy of you're in the matrix, right? Like, you know that this piece of steak isn't really steak, but you're going to eat it anyway because you're plugged in and you don't want to come out of the matrix and see what it really is from that, amazing movie from way back when. That's what it is with the healthcare system. Like, people know it's really bad. You know a story or two of somebody that's related to you or a church member or a family friend who had a bad experience in the healthcare system. And yet you just keep going to it because you think, it ain't gonna happen to me. And I hope that it's not. And I hope everything's going to be okay. And I hope it's covered. And I hope I don't have to pay that much. And then when you do find out that it really is happening to you, you just kind of say, okay, well, that's just the way it is. It's not. And that's a huge thing. So we've been going for a while. I want to finish out the beginning of segment one, or I'm sorry, the end of segment one, by talking about it from the doctor side, which PatientZero, you may not be the full-fledged physician yet. I know we're still in class at Google A University, but we're getting there to say some of these things I know you know to be true. We've talked about it before. So how many patients do you think are on a traditional physician's panel in a primary care setting, sorry, that on average you would say that primary care physician carries when it comes to a patient size? How many patients would you think in the traditional model?
Per day?
No, just panel as a whole, right? We already know that we see a lot of people per day, but technically every
Oh, like
physician has a panel of all the patients that are under their care. How many
kind of like your
patients?
roster of patients.
Correct. Correct. How many would you say on average if you had to take a guess?
Oh my God. If you're seeing 50 people in a day, I would have to say you probably got about 1,500, 2,000 patients
Yeah. So that's on the
under
lower
your
end.
panel.
That's the lower end. So the average is somewhere between 2,500 to 3,000. 3,000
You can't
bodies
care
that
for
you're
that much
technically
people.
exactly. So if
Like
every
look, and
physician,
look, no disrespect to anybody or anybody's skill set, but you can't care for 25, 3,000 people. You can't do it. I don't care how good you are. You could be Dr. House. It's not happening. It's just not.
more than likely you're Dr. Dre at that point. You just basically keeping them rocking because at this point
Yeah.
you just
Them
rolling at this
headphones
point.
fire.
Yeah, there we go. So the idea at this point is if there's an average of 3,000 bodies that someone's responsible for, there's
Can't do it.
clearly not good math to say how can you keep up with all those people, number one. Number two, how can you make sure these people are all being seen within a year? And then are they seen consistently at the level they need? Whereas one person may only need to be seen once a year. You may have somebody who needs to be seen 3 or 4 times in a month. And at that point, can it really work when you don't have openings because you have to see so many people every day? And my favorite is you also should, I don't know, take a break, have a vacation, have a life so you can actually be well energized and recharged as a physician. So
They're good
the
mentally.
idea, yeah, mentally, right? So you can have your cup full to pour into other people. You can't pour from an empty cup. But what happens is we are taught that doctors are basically somehow superhuman. They don't have fatigue, they don't make mistakes. And yet, when they need a day off, you now have to be rescheduled. And you've been waiting for 26 days to see this person. God forbid they have a emergency or a family issue or they don't feel well. So now they can't take a day off. You can't take time off because you don't want to miss this appointment that you've been waiting on. And it's just a huge barrier on both sides. And that's a huge problem. And nearly 60% of the US physician workforce basically, what's the word I'm looking for? Basically states that they will have some issues with burnout. 60%. Now, we're talking about on the physician side. Why? Because that's the one that I think most people will identify with. There could be other people in the healthcare industry that have the same, if not more, when it comes to them being burned out. The problem is what we tend to think is, well, physicians are burned out, we're just going to replace them with someone else. And then we get care that's watered down, care that's less experienced, care that's a lot more affordable. And at that point, we're wondering why the outcomes are still subpar. It's because you're basically replacing the high level people with those that aren't high level. You're getting cheaper labor, but you're expecting better outcomes. It makes no sense. So you're paying more for cheaper labor. The physicians are now leaving because they're like, to hell with this. I don't want to go into debt from a medical standpoint to go in to become a physician only to get burned out and now feel like I can't do anything about it. I'm going to do something else. So instead of more physicians being created, we're now then basically finding other people to come in and replace them. It's a really bad system. It makes no sense. And we didn't even get into things like moral injury, where people on the healthcare side feel like they can't do what they really and truthfully should do to help people, where people can't help patient zero get the care he needs because they feel like the insurance won't let them, or they don't have enough time, or they don't have enough coverage. All those things that morally make you feel horrible as a caregiver, but yet they tell you that's the way it is. We haven't even touched on that. So the system being so bad and so broken is something that's going to continue to happen, and it's not going to stop anytime soon. And I think that's why we, hopefully have painted the picture of hitting a lot of the high points. We didn't go into detail about how long the wait times are in the waiting room. We didn't go into the idea of how long it takes you to get a call back if you call to make an appointment and no one answers the phone. We're just talking about a lot of the easy things for people to understand, just to show you the system is bad. We need to do something else. And if we need to do something else, then what can that be? Well, I think it's direct primary care, and DPC is one thing that can be done, if not the main thing that should be done. So Patient Zero, before we close out for segment one, any other thoughts you want to share with the folks about the system and its shortcomings?
I think we've covered all the shortcomings. It's not good financially. The experience isn't the best, and you don't get the best care. I don't know what else can you say. I just want people to actually evaluate the situation.
Yeah, I think that makes sense. And I think the idea, if there is going to be a shortage of physicians, care cost is going up. The physicians are spending more and more time on documentation, administrative duties than caring for patients, because that's what insurance dictates and mandates. And you're getting worse care year after year, month after month. You're getting sicker and you're spending more. Like, why would you stay in that system? So
Right.
if you don't want to do that forever and you're feeling like something else may be better, let's really truthfully dive into that in segment two right after this.
Hi, it's PatientZero from the Byja Radio Show. Are you tired of the broken healthcare system? Frustrated by long waits, rushed visits, and sky-high costs? Yeah, I was too. So if you're tired of dealing with any of those things, then I highly suggest you check out the book Byja Blueprint, an introductory guide to direct primary care written by our own Dr. Byron Jasper. It breaks down all you need to know about direct primary care, a model that makes healthcare simple, affordable, and personal again. The book covers topics like how DPC differs from traditional insurance-based care, what's the difference between direct primary care and concierge medicine, how employers can use DPC to cut healthcare costs, how this model reduces burnout and improves work-life balance for physicians, and so much more. Whether you're a patient like me, a doctor fed up with burnout, or a business owner tired of rising healthcare costs, this book lays it all out in plain English. If you're ready for something better, check out Byja Blueprint, available in paperback, audio, and ebook format. Visit bookstoread.com/Byja Blueprint DPC and get your copy today.
And we are back from break for segment 2 of episode 40, Patient Zero. And I think we were under the impression that we were going to have enough time to do 2 segments. The first segment being about how broken the healthcare system was or is. And from that, we would then pivot to how direct primary care works and do a real deep dive into DPC. But it seems like that's hard to do considering how bad the healthcare system is. And we spent so much time really pointing out a lot of those gaps in care, gaps in billing, gaps in premium cost, and all these things that we know to be self-evident. We know they're problematic, and that now has us going extremely long in the first segment and doesn't leave us enough time to do the direct primary care segment justice. So you and I spoke during the break, and what we came up with is we are going to break this into 2 parts. And I think that allows us more time to really dive into direct primary care, how it works, and give people that deep dive into things that we are not only familiar with, but questions that come up and misconceptions that come up all the time. And I think you would agree with that, Patient Zero. So before we close out, because again, we've been going for a while, I want to know your thoughts on anything that we've covered in part 1 that would be helpful for people to realize that really focuses in on from a standpoint of the broken healthcare system that is currently in existence. And it could be anything, right? We were talking about legislation, we were talking about wait times, we're talking about premiums and deductibles. What are your thoughts that you would say this is probably something people really need to do, and not necessarily about, pulling the numbers and doing things like that? I know you can say that. I want to talk more about what would you encourage people to do or not do that may help them reassess that system where there's a gap and say, okay, well, think about it like this. Anything that, kind of comes to mind?
So I think about just changing times, right? I think about how entertainment used to be when, we were kids, right? You go to the movies, you had to look at the movie times in the newspaper, and then you had to go. Oh man, I'm old. You had to go to the movie time. You had to go to the movies based on the times in the newspaper. Um, Everybody had house phones. You just think about the anxiety of calling the young lady's house and asking her parents if she could come to the phone.
Mm-hmm.
I think
You
about
preaching,
once we
brother.
got
You preaching.
right. Well, think about all these things. Think about how you had a report to do when we were younger, and we would have to go to the encyclopedia, because I was fortunate enough to have an encyclopedia at home, or you had to go to the library, right? Think about how, once we did get internet, you had to use dial up. You had to choose between using the phone or the internet. You had to wait for a song to download if it was a song that you really, really wanted to hear.
Mm-hmm.
You think about those things. And then think about how everything evolved and we've adapted, right? Think about how, just a few years ago, it was a foreign idea to have internet on your phone. And now we're walking around with internet in your pockets. Or think about how everybody paid for cable TV, and it was so much anxiety from a lot of people to cut the cord. You think about all these evolutions, right? And I could kind of go on and on about technological advances, just the way the world has changed. The only thing that hasn't changed is your healthcare, because you had insurance back then, and you went to the same doctor. You were getting 7 to 10, 15-minute visits in the 90s. You're still doing it. Insurance and healthcare is the only thing that we've done the exact same way since I've been living. And a lot of these adaptations have really benefit us and made our life more efficient. Like, can you imagine having to pull up a web page and wait for it to load?
Mm-hmm.
Can you imagine paying all these cable providers these high cable bills? Can you imagine having a house phone and not having a phone to call if you got a flat tire, or like Or if you forgot something at the store and you couldn't call the missus at home. Like think about all these things and how much we've looked at these changes as a no-brainer.
Yeah.
Why are we so married to this same healthcare system that has remained the same for decades?
Mm-hmm.
I'm not saying that you have to just absolutely change everything, but at least consider a change.
Yeah.
At least look at it.
Yeah.
Because, we've progressed in every other avenue of life, because the thing about it, you look at your car. I got way more stuff in the car, like in the Chevrolet. I got more features in my Chevrolet right now than a BMW had 15 years ago,
Mm-hmm.
or a Benz had 15 years ago,
Mm-hmm.
or a considered luxury car.
Yeah.
You know what I mean? Like, we've adapted and we've changed in everything else. Why is this the only thing that stayed the same? Just for me personally, I urge you to take a look and consider something different.
Yeah. And I'll frame it in a different way that may be a briefer, more succinct way to say it. Either you're going to evolve with the times or you're going to end up extinct. One of the two. And I think a lot of people can think from a morbid standpoint, extinction means basically the
Yeah.
opposite of what we are trying to do when it comes to
Right.
healthcare. So why not evolve with a system that hopefully will promote you being here longer, your family members being here longer, your business being here longer if you're an employer, because now you're not breaking the bank for employees that are going to end up sicker and cost you more money anyway. Like, it doesn't make sense. And what I'll say for my pre-closing, because we always close out by telling people where they can find us off of Byja Radio, I'll say, and I'll give people a little bit of knowledge, because I always believe in hopefully giving people something that they can take away and say, I didn't know that, and I'm glad that I listened because I learned something. In February of 1971, PatientZero, I'm going to dig into the vault. And when I heard it, I just put my head down and I said, that makes so much more sense now, how we got where we are. In February of 1971, there was a president by the name of Richard Nixon. And Richard Nixon has a recording that you can go back and listen to where he's in, if I remember correctly, the Oval Office talking to a man named John Ehrlichman. And John Ehrlichman and him were discussing the profit incentive to insurance in healthcare in 1971. Before that, insurance for the most part operated like, if I remember correctly, home insurance, where you really and truthfully used it for big stuff. And at that point, it would pay out because you had something catastrophic happening. But in 1971, somebody came in with an ulterior motive. I don't know what the motive may be, maybe something called profit. And they basically decided that the incentive for this type of insurance plan, called an HMO, a health maintenance organization, is actually meant for the insurance company to make more money by giving you less care. It's literally recorded and documented. It's not me making it up. It's not PatientZero making it up. It is literally a politician and other politicians who don't give a damn about you, literally playing with you, your family, and your family's lives and well-being to make money. Tell me if that sounds familiar, PatientZero. Anything like that going on now? Can't be, right? No way in the world that could be happening in 2025. But that is literally showing you where it started, possibly. And if not, it may have started a little bit before then. But the documentation that at the highest level of government within the United States, they were literally saying the incentive is they give you less care, they make more money. Go listen to it. And what did that go and become, PatientZero? The Healthcare Maintenance Organization Act of 1973. So in 71, they started scheming. And by 73, they passed legislation to make you spend more money, give you less care. And yet, we're going to sign it into law. Does that sound familiar? As the statement goes, if you don't know your history, you're bound to repeat it. So I'm
Yep.
telling people that if you've listened this far, you're at, minute 50, 55, whatever we want to call it, whenever we're done doing everything, and you have this going through your headphones, through your car radio, through your computer speakers, listen to us when we tell you we're not making this up and we're not on soapboxes just because we don't have nothing else to do. We're very busy. We're trying to make sure that you and your family live longer and that you save money and you're not digging yourself into a hole and wondering why you can't get out of it from a healthcare debt when it could have been something you prevented by just saying, you know what, let me try what they're talking about. I may not get it right, but I'm going to just try it. And if it works, I'm going to keep doing that. If it doesn't, I can go back to what I was doing. It ain't going nowhere from what we can tell. And it's not going to necessarily hurt you to try something else from what we've talked about. But if in 1971 this scheme started and it's been going on for this long and it's not getting any better, what do you have to lose other than potentially some time and some effort? So that's it, PatientZero. I will literally get off the soapbox, at least for now, hopefully dropping knowledge. And I'll ask you, where can the people find you between now and part 2 of this amazing episode on why direct primary care is needed? What do you got, PatientZero?
Well, they can find me at Becknell Media on Instagram, George_Becknell on Twitter, and I'm still calling it Twitter. I don't care. And George Becknell II on LinkedIn. That is me.
Let me ask a specific question. If you could rename it, obviously it's not going to be X. You still going to call it Twitter. But if you had the opportunity to rename it, what would it be?
142 characters.
That's a long name, brother. That's a long name.
Well, we'll name it 142.
I like it. Much better.
142.
More descript. I like it.
So, yeah. But you put me on the spot. I didn't, but I might have a better name in part 2.
I like it. For us, you can find us on our website at www.byja.org. That is Byja Clinic. You can find our nonprofit organization at Byja Charitable Alliance, which is www.byjaca.org. Our social media is Byja Clinic, and that's for LinkedIn, at Byja Clinic on Facebook and on Instagram. And last but not least, if you don't already know, you can support us and get the word out about direct primary care in a book format. We have it on ebook and on paperback. It is the Byja Blueprint, an introductory guide to direct primary care for patients, physicians, and businesses. And that can be found on books2read.com, BOOKS, the number 2, read.com/Byja Blueprint DPC. And outside of that, you really and truthfully can find us always at Byja Radio Show with myself and the amazing PatientZero. We will close out officially, and hopefully you'll join us for part 2, where we do our deep dive into direct primary care, how it works, addressing myths, misconceptions, all that stuff. It's really going to be just direct primary care. We're not going to be on a crazy soapbox. In my mind, PatientZero, I don't know if we can guarantee it, but I'm going to really try that we're not going to do it. And for that, you can come back and see us then. Like, subscribe, share, follow, comment, all that good stuff. We appreciate you. We really, really, really do this from the standpoint of love and care and all that good stuff. But we really do mean it when we say we appreciate you. So thank y'all for listening. We'll see you next week.